مساء الخير على حضراتكم جميعا. معاكم محمد البراي. انا برحب بحضراتكم في كورس جي اي موتيليتي فور اول. طبعا انا بتشرف بوجودي مع حضراتكم. I'm so sorry. دكتور نومان. Hello.
How are you?
I used to talk in Arabic. I'm sorry, I started in Arabic. I would like to welcome you all. This is Mohammed Brai talking to you for GI Motility for All course. It's my honor and pleasure to introduce my colleagues alphabetically. We have Dr. Amr al-Mustikawi from Al-Azhar University, and we have Dr. Iman. 1 minute, I have to go alphabetically, sorry. Dr. Dina Gamal from Ain Shams University, Dr. Iman Said, Alexandria University, Dr. Maha Al Husseini, Alexandria University, Dr. Marwa Abu Kresha from Asyut University, and this is Muhammad Al Barai from Al Azhar University. We are honored to have you all, and we have the pleasure to run this course for the first time this year. And we also are glad to have more than 300 participants and 300 requests that have been submitted to join the course. But as you know, the number should be limited to maximize the benefit for everyone. And we have chosen 50 to start with for this course. I know that the online could be expanded, and we are expecting to expand. We have a lot of requests from the colleagues in different countries, but the hands-on will not be expanded. We will try to limit the number to be suitable for training to get the most benefit of the course. Quickly, I'd like my colleagues to welcome you one by one. So we'll start by Dr. Amr, and then Dr. Iman, Dr. Gina, Dr. Maha, and Dr. Marwa, please.
Dr. Muhammad, thanks for this course, and I welcome all of the attendees and my colleagues. I honor to be a member of this Motility for All. I hope, inshallah, to be benefit for all the participants, inshallah.
Thank you. Regina?
Welcome all. It's my honor to share in this great motility course. Thanks, Dr. Muhammad, for coordinating this course. We are hoping to get all the benefit from this course, and welcome all. See you soon.
Thank you. Dr. Iman?
It's my honor to be a part of this course. Welcome to the GI Motility for All. We hope that you will benefit from this course to the maximum. Thank you.
Thank you. Dr. Maha?
Good evening. Hi, everyone. I'm super excited to be among this fantastic group, the GI Motility for All. And hopefully we can giving you all our best to start your own clinics and to start your own motility work. Thank you.
Thank you, Dr. Maha. Marwa? No, you are muted, Marwa. Marwa, you are muted.
Welcome, Dr. Muhammad, and all members in this motility course. I hope all gastroenterologists get the benefit from this course to put your patients on the right track, best diagnosis, best treatment, and welcome in this course.
Thank you very much. Finally, as Mohammed Abra, I welcome you again, and I will go straight to the course overview. As you know, in the previous contact with you by email, we have explained the course, but I just want to give some more information about the course. The course is the first course of our group, and this group is under the umbrella of the Egyptian Group for the Study of Gastrointestinal Motility and the Middle East Club of Neurogastroenterology and the Egyptian Society of Academics in Gastroenterology and Endoscopy. These are the course faculty that you have already seen before, and they talk to you. The participants of the course are expected to have a lot of information about the motility. It is not an online lecture or a webinar. It's a complete course about motility that allows everyone at the end of the course to practice motility at ease. So the course, it will be a longitudinal one. It will be all over the year. Expect that we will have a meeting every week. This meeting should be attended by all of us. You have to attend at least 60% of the course to get the certificate at the end of the course from these three entities. For colleagues who want the hands-on training, they will come to Egypt and we will assign one of our centers to be responsible for one of each training. And we have also expanded our course to include faculty from Egypt, from the Middle East, and from Europe, and also hopefully some colleagues from USA will join us. We are trying to make this course very valuable and very informative and very inclusive. So from now and later on, uh, consider yourself as one of the instructors of the course, because you will convey the messages you learned here or you participated here to your colleagues in your country or your hospital or in your department, and expect a lot of interaction during the course. So we target the gastroenterologist mainly because we are all gastroenterologists, but also we can involve surgeons and GI fellows as well. The motility lab technicians and the nurses, hopefully we can develop an online program for them, but this will be in the next year because we need to have a number of qualified practitioners or motility technicians that who can talk in English fluently to convey the message. But meanwhile, this year we will teach our local technicians parallel to our courses. As I mentioned, the course is 12 months to 14 months. We will have 8 to 10 webinars. We will have 4 in-person meetings in Egypt, and each meeting who hands-on training will last for 2 days. The times of the webinar, I think it should be suitable for everyone. It will be on Friday evening, and this is suitable for Egyptian and non-Egyptian and people in the Middle East who have Friday working day or Friday not working day. So I think 19 to 22 time, 3 hours will be suitable. It will be once a month only, and the other assignments that will come in the other weeks, we can adjust the time based on our availability of each group. So the physical hands-on trainings will be on Thursdays and Fridays, and it will last the whole day from 10 p.m. till 4 p.m., including the breaks. I am Mohamed Barai, the course director, and we have honorary board from the Egyptian group of the study for gastrointestinal motility. This was established in 1995. Those are the course faculty. You know them all now. And those are the honorary course faculty and the chairpersons for all the sessions. We have Professor Mahmoud Osman. He is the president of the Egyptian group for the study of gastrointestinal mortality. Professor Hisham Sawah, Professor Fatma Murad, Professor Osama Al-Baili, Professor Osama Abada, Professor Magdi Hamid, Professor Baha Abbas, Professor Asama Abdul Mohsen, Professor Said Abdullah, and Professor Ahmed Kandil. Professor Ahmed Kandil is actually an oncologist, a nuclear medicine specialist, and he will teach us the part of the gastroparesis and the scintigraphy. We are honored to have the international faculty from Pakistan, Dr. Shahab Abid, and from Lebanon, Dr. Fadi Daniel, and from Turkey, Professor Serhatpour, and from Saudi Arabia, Professor Ehab Abu Farhana. Those are the initial international faculty, but we have a lot of as I told you, a lot of participants from different parts of the world, including Europe and US. They will come later on in the coming webinars. This is the schedule. I will not go in much details because they are all the same. This is our introductory meeting that we explain the course, what we will do in the course. Each one responsible for a webinar will explain it for you, what will happen during the webinar and the weeks after. So we usually start by one webinar about the basic information. So in February, we'll start the basic high resolution esophageal manometry, and Dr. Amr al-Mistikawi will be responsible for that. And the second week, we will put assignments at the end of the webinar that we will work on it. So week 2 is not working week. We will work on week 1 as a webinar, work week 2, we will have the assignments done, and week 3, we will have the discussion and review of the assignments, and I will explain this at the end of the meeting. And week 4, we will have some application of case studies. This will be repeated for each webinar. For example, in March, we have impedance pH metry. Dr. Gina will be responsible for that. And we will have, after these 2 webinars, hands-on training in April in Cairo. And in May, we will have a high resolution anorectal manometry by Dr. Marwa. And on June, we will have, this is in May and June, we'll have the biofeedback by Dr. Maha. And in July, we'll have another hands-on training on anorectal manometry and biofeedback. In August, we'll have advanced level of the high resolution esophageal manometry. In September, we'll have the advanced impedance pH metry. And in October, we'll have another hands-on training on advanced high resolution esophageal manometry. And in November, we'll have advanced high resolution anorectal manometry. And December, we'll have advanced biofeedback webinar, and then hands-on again in January 2027 for advanced anorectal manometry and biofeedback. And in February, we will wrap up the whole course and start the next course in March. So for today, we will go through the webinars one by one. Each one of us will explain what we will discuss in the webinars. Hopefully, we will have Dr. Osama and Dr. Mahmoud Osman as chairpersons for this session. If they have time, I send them, but I think they are busy today. So I will leave you to enjoy the course with our colleagues, and I will start with Dr. Amr al-Mistikawi. But if you have any questions, please unmute your mic and ask me now. So I expect a lot of questions. Don't be shy and go straight and ask. Okay. Dr. Ahmed Zaid,
أهلا دكتور محمد.
you have any questions?
يعني لسه بندخل في الموضوع.
Okay, fine. طيب يعني for the structure itself, is it okay?
It's okay, but يعني I hope يعني to يعني give us the exact time for hands-on to prepare tickets and come time. يعني.
Okay, this is a very good question. We will do that within 1 week, but let us put dates only for the two hands-on, the coming 2 hands-on. We will
Yeah,
not
no
put the 4 because
Okay.
we have to agree on the dates because there are too many colleagues from different countries.
No problem. Okay.
Okay.
But يعني Thursday and Friday mostly. يعني.
Yeah, I mean the 2 hands-on trainings. The first one will be esophageal, and the second one will be anorectal. Our biofeedback and pH impedance. We have to agree on that in our first webinar, and then we will postpone the other 2 till the end of the year.
Okay.
Okay. Later
Okay.
on, I mean, in April or May, we can assign those dates.
Okay, no problem.
Because we have a lot of conflicting requests for that. Some people need the training during their annual vacation in August. Some others need it at the end of the year in December because the Christmas. I have received some requests like that. Okay.
Can we mix 2 hands-on together? يعني 4 days for the 2?
It will be difficult, but if we need a condensed course, then we will discuss our faculty together if we can be available for the 4 days, because everyone is from different city.
Okay, no problem. خلاص, we can deal with 2 days every hands on إن شاء الله.
Okay. So, if no other questions, Dr. Amr can proceed, please.
Dr. Muhammad, again, thank you for building up and organizing this group. And again, welcome with all attendees from the different countries. I hope inshallah to be useful for you. I will be responsible for the esophageal manometry, and this one I'm not discussing today the test itself, but I will show you what we'll do during the course. I hope inshallah to be useful for you. I'm Amr Mistakawi from Al-Azhar University. And the esophageal manometry, I think all of you know about this one, and I think interesting part, and I think is enjoyable part also. This one, and it must be we will talk about the anatomy of the esophagus and the anatomy of the esophagus layers and what the range of diameter and what is the range of diameter can cause problem. And also this need for the patient from the start from non-obstructive dysphagia. We know you have mechanical dysphagia, we have a non-obstructive dysphagia, and this test mainly for non-obstructive dysphagia and another disease we'll discuss later on. All of us minded it's a new technique. It's actually is very old technique from the previous century. Okay, the concept is to evaluate the movement and swallowing in the human, and this is starting at 1892. And after the World War II started to have in my clinic and Boston University focus about the pressure inside the esophagus, and this one starting to put the balloon inside the esophagus and testing the pressure and evaluating the pressure. In 1970, okay, conventional manometry started to become really test for the dysphagia, and the 19 become testing the topography of the esophagus and start to make a shape or the color or the idea of the color of the test. In 2000, okay, start to have idea about high resolution and start to test about the esophagus pressure in topography and the color mood. And 2008, okay, start to have classification of the disease during the test. The most and famous one, the Chicago classification, started by Chicago classification 1 in 2007, 2, 12, and 3 at 15, and finally, and now the standard is 2020. We'll discuss this one in details and the disease linked by this classification. Our agenda during the course would be, I will be concentrating to make sure you have when to do the test and how to do the test and how to interpret the test. And if you answer this question, will be very professional in the test, inshallah. Start with to do the test. We need the patient, and we need the doctor to have patient this problem and understand this problem to refer to us. And to do the test, we have machine and we have catheter to go inside the patient, and after that to read and interpret the test. Our indication mainly in the test for non-obstructive esophageal dysphagia. The obstructive or the dysphagia is not in our range, so patient must have endoscopy and must have imaging test for the barium swallow to be sure we have no mechanical obstruction. And the test also can be done for preoperative anti-reflux surgery, and very, very important nowadays because to avoid complication after the test and after the surgery. And the non-cardiac chest pain, and this nowadays is increasing in prevalence. Okay, patient have cleared from the cardiologist and the pre-esophageal device implantation as BH metry. The test itself cannot do because somebody asked me if he's important and standard test for the dysphagia. Why I will do the barium and endoscopy? Actually, barium endoscopy also the history is not so important. We'll discuss in detail. The barium using in barium in the disease and the exclusion of the mechanical obstruction. The endoscopy test also will discuss this one. And this one is the complementary test with manometry to reach the good disease. Non-obstructive dysphagia we'll discuss in detail. as manometry is a gold standard test of achalasia and something else, that subtypes of the non-mechanical obstruction. And preoperative for the anti-reflux surgery is most important nowadays to rule out achalasia to assessment of the contractility for surgical decision. Maybe patient not need operation or maybe a modification of the surgery. And this one to avoid post-surgical complication. One of the main indications now is not cardiac chest pain. You should have chest pain and they create from the other specialty as mainly cardiac, and we have severe gas. We need to diagnose the patient, and we have disease, and we have solution for this problem. Pre-placement of the esophageal device to identify clearly the lower esophageal sphincter to put the device at correct site. If we have patient with this criteria and we need to do the test, if we do the test, must be have machine and we have a catheter. In this section, we'll discuss with you the machine itself, the available machine in the market. Mainly, we have machine, some company producing the machine, like Labori, like other company, and the composition of the machine itself in details, and also discussing the type of the catheter. We have mainly two types of catheter, water perfuse and solid state catheter. Each one have benefit, each one have advantage and disadvantage. We'll discuss the procedure details. If you have patient and we have machine, we'll do the test. So we'll discuss also the preparation of the patient for the test. Consenting must be taken the consent of the patient, well written. And fasting also, and we have kind of fasting more than for each patient more than other, because patient of achalasia, not like patient normal. And the cooperative patient, you must be select your patient to have good test. If you have machine and we have catheter and we have patient, we're ready to do the test itself. The first one will discuss the catheter calibration, because every catheter from this one, either solid or the water perfuse, must have calibration to make all the sensors have the same pressure before putting in the patient. And the catheter placement to introduce the catheter inside the patient through the nose, okay, to the esophagus, through the esophagus to the stomach, and this is the technique we have. We have a special technique, and we have side effect must be discussed in details to have safe placement of the catheter. The procedure itself will discuss the detailed steps in the of the test, okay, as resting pressure, what's the meaning, what is useful for the patient, deep pressure, deep inspiration, basal swallow, all of this one, and the procedure itself and the swallow to get this picture in for the patient. And this picture will discuss what does this mean, what does the kiss color mean on each area, okay? What is the indication like that? And if we make this pressure picture like that, we know the picture like that, we'll know the normal, and after that we'll discuss this in details. And also we'll discuss the manometry metrics, what's meaning of each one, what's meaning of the break, the DCI, DL, and also IRB, and what is the importance of normality, normal value, and what is the indication of the disease. Also, we'll discuss the Chicago classification in details, because now we have standard Chicago classification, and also this one changing from time to time. We have the Chicago 4 now. There is 3 edition before, it modified by time, and now we are the standard for the esophageal manometry and disease of the esophagus, either weak contraction or strong contraction or failed contraction. All of this one, inshallah, will try, and with our colleagues, okay, to have and achieve correct diagnosis for your disease and your patient. This disease will discuss in details as achalasia in the types, type 1, type 2, type 3, what is the criteria, what is the manometric and metric changes, and what is the indication for this one, what is the difference between each type, what is the beneficial effect of the test for the patient. If somebody talk to me about is achalasia in the end, no, 1, not like 2, not like 3. And also we have esophageal gastrojunction obstructive outflow. This one rate, but we'll discuss also. We'll discuss in another way, okay, the esophageal weak contraction disorder. What is the meaning of the absent contraction, failed contraction, or ineffective contractility? Well, also, what is the impact of this one on the patient? What is the diagnosis of the disease in some patients? Also, we'll discuss the hypercontractility disorder as distal esophageal spasm and jackhammer esophagus, and this one may be linked by chest pain in some patient. All of this one we'll discuss in details, how to do, when to do, and also interpret all the tests, inshallah. We'll try with my colleagues to make it very simplified, very basic, inshallah. At the end of the test, we'll be able to make the test and to read the test. I hope, inshallah, also to make a discussion for one of the most discussable point is the hiatal hernia on the test. This one is requested by every surgeon. I think if you have surgeon now, he would be like to understand the test in this one, how to do and how to interpret also. So high resolution manometry, if you reach correct diagnosis, will inshallah have good decision of intervention, and this one will avoid make avoidance of the complication or failure of the intervention. I hope, inshallah, to make effort for you and to make effort, inshallah, to be able to read and to make the test easily and simply. And inshallah, at the end of the test, you will be perfect in the esophageal manometry. Thank you so much.
Thank you, Dr. Amr. A very nice presentation and a good overview about the course of the high resolution esophageal manometry. So if anybody has questions, please go straight to ask.
مش عايزك تسأل ازيك يا بيه؟ ازيك رحمة؟
يا دكتور محمد، دكتور عمرو، ازي حضرتك؟
ازيك يا بيه اخبارك؟
الحمد لله تمام. طيب.
So, if no questions, we'll move directly to Dr. Gina. Okay, Dr. Gina. Yeah, please.
Yes, Dr. Muhammad, I'm starting sharing.
Please.
Okay, hello everyone. In our pH impedance course and its clinical application, at the end of this course, you will be able to know difference between pH catheters and pH impedance catheter, and to know the importance of combining both pH and impedance. Also to know indications, clinical applications of pH impedance testing and how to do the test adequately and how to interpret the test accurately. Then lastly, pitfalls in pH impedance testing. As we know, GERD is a very common condition in the gastroenterology practice. Usually most of our cases are is a common GERD and anything else as a disease. So
Gina,
GERD is a very common.
Gina, can you just make the screen bigger a little? Make it full screen? Yeah. From here, yes. Thank you.
Is it good? Okay.
Yeah, thank you.
Classical techniques like endoscopy was the only used procedures to diagnose such disease for patients with symptoms related to GERD. But we can meet many patients still symptomatizing, also on treatment. They are still complaining of refractory GERD symptoms. So after exclusion of mimics for the GERDs, we need to confirm the diagnosis that they are refractory GERD or other overlap syndromes. So referring to the American guidelines, any patient with heartburn, regurgitation, any symptoms of insufficiency not satisfied on treatment, after trial for 8 weeks on PPI, the patient should go for endoscopy of PPI, 2 to 4 weeks of PPI, and then you should classify your patient as grade B, C, D, or Barrett more than 3 centimeters. So you had confirmed that your patient is a GERD patient. But for cases with normal endoscopy or classification grade A, you should confirm by reflux monitoring to confirm that the patient is GERD or not. So, returning back to our patients who are not responding adequately to the treatment, you should go for 24 pH impedance monitoring, which is a gold standard now for diagnosis of the GERD. Let's revise with each other the Lyon criteria. It's a combination between endoscopy, pH impedance, and the high-resolution manometry to confirm that your patient has a true pathologic GERD versus he has a functional disorder or overlap syndrome with reflux hypersensitivity or functional disorder. So it is not easy in all patients. We will know what is the indication, what's the importance of esophageal pH monitoring, and how it's used for the highly acidic refluxes. And also we will know the difference between it and between impedance, as impedance will measure the resistance any alternating current in the lower esophagus. So we will know the difference between both in details. Impedance depends mainly on the direction for the electricity for which liquid or gases boluses are propagated. So it will help more in diagnosis patients. Also, we will discuss how to prepare your patients to get adequate, accurate testing, how to prepare your patient, fasting, when to stop treatment before the procedure, and when to do the procedure on PPI. We will discuss all. Also, to be ready for the test, how to let your device ready, how to calibrate your catheter and the electrodes to get an accurate test. We will discuss the steps for the test, how to connect patient adequately, how to place your catheter in a correct position, and how to complete your procedure totally. We will discuss about the good positioning of the catheter, as if the catheter is not in a correct place, all the tests will not be adequate. Also, we will discuss how to explain to the patient after completing the procedure, how to explain how to use the device. It's very important because each button in the device has its specific rule, so the patient should know the importance of each one. We will discuss how to use each button separately. And then finally, reaching the interpretation, we will discuss about the acid exposure time, the bolus exposure time, and how to interpret it in the report. Also, symptom association indices, including symptom index, including system association probability, and how to diagnose whether the patient is truly have symptoms in relation to the refluxes or it is functional disorder. We'll discuss advantages and disadvantages of the pH impedance monitoring and its clinical utility in all your patients. Also, one of symptoms which is bothersome to the patient is the belching. So pH impedance will differentiate between gastric and supragalchic belching. Also, patients which are not straightforward, like patients of atypical symptoms for the GERD, cough and hoarseness. So you will get benefit of the testing and for diagnosis such patients. So all patients with GERD may not need physiological for confirmation of abnormal GERD. They are essential in subset of patients. Castor-based 24 pH impedance monitoring scores over the conventional pH monitoring. 24 hours monitoring is easy to analyze, and these physiologic testing are also useful to respond to pharmacological and non-pharmacological treatment for patients. So it's very important to get an accurate data from a correct test for the patient, and so to guide the patient for the management plan. Thank you.
Thank you very much, Dr. Gina. Can you just end the slideshow? One more click. Yeah, thank you very much.
Sorry, Dr. Mohammed.
No, it's okay. It's okay. Thank you. Very nice information about the very important course. It's now the what's called state of art for everyone, for each surgeon, for each endoscopist doing ARMA and TIF and Isofix, etc. So I congratulate you, Dr. Regina, for this very important topic, and I open the discussion for questions for colleagues.
Okay, one question best for the last sentence Dr. Gina mentioned.
Sure.
Is it recommended to do again the test after medicine to check response?
On treatment, when to do on PPI?
After the last item you said it is can you open the last slide?
Okay, last one. About to decide the management for the patient?
The last point.
Okay.
Useful to assess response to pharmacological and non-pharmacological treatment of GERD.
Yes, sure.
And you can after medicine and improvement of the patient, it's recommended to do the test again to.
Okay. I think this is a difference between when to do the test on PPI. If the patient is still complaining of reflux symptom and you give him maximum doses for the PPI, you will need to know whether the patient has his heartburn or his refluxes has been controlled or not. You should repeat the test on PPI. So if the patient is controlled as a refluxes and he is still complaining, he maybe have overlap syndrome as a GERD and functional element. He's still complaining, and you noticed a difference and a big control in the reflux events after treatment, on treatment. So reflux had been controlled on PPI, but he is still complaining. He may be overlap syndrome between reflux and the functional, or reflux and the hypersensitivity.
I think
But
this
if
overlap
you
can be diagnosed from the start if we did the test.
okay,
And doing the test of
let's
PPI
revise.
or on PPI according to those presentation.
Okay, let's revise. First, if the patient is complaining of reflux and you need to confirm that he has reflux or not, pathogenic reflux or not, we will do the test of PPI to confirm the diagnosis that he has reflux. Okay, so the second step, if your patient has been diagnosed as reflux already and is still complaining on maximum doses for PPI, you will need to know if his reflux is in control or not. Also, he is still symptomatic. So you will repeat. Yes, you will repeat the test on PPI to confirm if still he has refluxes and acidic refluxes on PPI. So you should change the PPI, or you should change to another class or to rise the dose, so the PPI is still not controlling your patient. But if the patient is controlled by repeating the test on PPI, he is controlled as results, as refluxes events, but still complaining, you will check for the association between symptom and refluxes. So it may be overlap between reflux and functional, or reflux and hypersensitivity on PPI in already diagnosed patient.
Okay, thank you.
Welcome, dear.
Thank you very much, Dr. Ahmed. Any more questions? Okay, I would like to welcome all colleagues who have joined us now. We have started by giving an introduction for the course, and each instructor has to introduce his course to the whole colleagues. And we started with Dr. Amr. He talked about the high resolution esophageal manometry, and Dr. Gina talked about the pH impedance. And now we'll move to the anorectal manometry with Dr. Marwa. I'll start sharing my screen. Okay, please go on, Dr. Marwa.
Now we reach to the dark area and the dark tunnel in the motility lab. Basics of high resolution anorectal manometry. Next. The aim of this course to help all gastroenterologists puts their patient suffering from GIT disorders on the right track. For accurate diagnosis, use best modalities for investigations and precise plan for treatment. Next. Let's start with this case from the motility lab and how we decided to manage this patient. Male patient, 45 years old, teacher from Egypt, married, has 2 daughters with no special habit of medical importance, presented with chronic constipation of 7 years duration in form of daily desire to defecate with severe strain, hard lumpy stool. Sometimes use the manual maneuver and water tap to defecate. Full lab and colonoscopy, normal. Next. Female patient, 55 years old, married, from Egypt, presented with chronic constipation of 5 years duration in form of severe strain during defecation, hard stool, using also water tap during defecation. Also, full lab and colonoscopy is normal. Next. This case coincides with the surgeon specifically. Male patient, 33 years old, from Egypt, presented with fecal incontinence of 1 year's duration due to motor car accident with complete perineal tear and anal sphincter energy with intact nerve supply, which means we have injury to the muscles and the nerve is intact. Next. So, the patient needs help between constipation and fecal incontinence, which is our rule in the motility lab to put the patient on the right track. Next. Next. All of us know different motility to diagnose the constipation and the fecal incontinence. If this patient needs colonoscopy, if this patient needs to escalate drugs between different groups for constipation, or need high resolution in rectal manometry, balloon expulsion, MRI defecography, or colonic transit. All this modality for diagnosis, how we can precise the best one to reach accurate diagnosis. Next. Anorectal manometry. Does this patient need testing? هل يعني if this any patient from our cases need anorectal manometry? This is the question and we find the answer with you. Next. This is high resolution anorectal motility lab, which is computer designed with different catheter, either water catheter or solid catheter. This is the 4 catheter from the major company worldwide. Next. In this course, we need to know high resolution anorectal manometry. What is the indication, the contraindication, the complication which may occur due to this maneuver, how to perform a high resolution anorectal manometry technique, analysis and interpretation, and finally, the London protocol technique. Next. In the normal high resolution anorectal manometry, we must know this terminology: normal anal sphincter, anal squeeze pressure, cuff reflexes, rectoanal inhibitory reflex and its interpretation, simulated defecation, and the rectal sensation. Next. What is meant by International Anorectal Physiological Working Group recommendation, which is the standardization test protocol and the London classification for disorders of anorectal function. This protocol discuss resting conditions, the time for the squeeze, the time for endurance squeeze, how we perform the hypersensitivity of the rectum, either hypersensitive or hyposensitive. This is by every second during which your patient puts a catheter. Next. Also, everyone use the catheter of anorectal manometry must study this figure well. Every time we record the change in the pressure of the rectum and the anal sphincter on the catheter during the rest, during the squeeze, and during the bearing down, which means during the defecation. Which area show increased pressure and which area show decreased pressure? Next. Complementary to the high resolution anorectal manometry is the MRI defecography. Some patients need to start with MRI defecography, and other patients need to start with high resolution anorectal manometry. Also, in some places, there is no available test for diagnosis. So, we must study the change in the MRI defecography and its corresponding pictures in the high resolution anorectal manometry, which by all this test must be complementary and represent the exact symptoms of the patient. Next. Abnormal high resolution anorectal manometry. At the beginning, we start with most complaint in the motility lab and the most complaint in the gastroenterology clinic, the constipation. Constipation, it may be of small intestinal origin and may be of anorectal origin. As regards small intestine, it is will be mentioned in the advanced high resolution anorectal manometry course. However, anorectal function in this basic course. One of the most common disorders is defecation dysynergia, and in Hirschsprung disease, which is common in the pediatric group, and we have a variation of Hirschsprung in the adult, which also discussed in the advanced note in the basic course. Next. As regard the fecal incontinence, investigation of the incontinence, which may be in passive incontinence or urge fecal incontinence, and complementary to manometry, the anorectal EUS. Next. Our mission in this course to reach the success for accurate diagnosis of the functional and maybe some organic anorectal disorders. Best wishes for you in our course, and everyone must be at this course to be able to use an anorectal catheter to help his patient. Thank you for all.
Thank you very much, Dr. Marwa. This is very complicated, let's say, but
It is the dark area.
okay. But let me tell you one thing. Personally, I felt that anorectal manometry is easier than high resolution esophageal manometry. I don't know if other colleagues agree with me or not, because the anorectal manometry is a very primitive protocol that is developed based on the available information, and they are updating now. So there are no much tricks in the anorectal manometry as I understand. And I feel comfortable when doing anorectal manometry rather than high resolution esophageal manometry. What's your opinion, Dr. Maha?
Hello again.
Hello.
I'm not, I don't agree with that, because we have lots of unanswered questions in the anorectal manometry. That's why, and that's because the London protocol is very primitive, and whoever puts the protocol, they know that by heart, and they are doing much effort now to update with all the answers to the questions that we don't know. For
That's
example,
why nobody knows even anything. Nobody knows anything.
yes,
To diagnoses, and that's why it's simple. However, the
simple because
esophageal has a
yes.
lot of diagnoses.
Yes, because in the esophageal part, they've started their work many years ago, but it's very primitive, as you mentioned, in the anorectal manometry, because it's something new.
Yeah. Okay. I think
If Marwa called her session is dark, I don't know what is my session will be called.
let's open questions for the dark part first, please.
Right.
Okay. Any questions for Dr. Marwa, please? No man.
احنا هناخد كل ستيب بالتفصيل ولا قدام يعني ولا هو كده بس الالكترومانومتري؟
Who's talking in Arabic? Are you Egyptian?
Yes, I'm Khalid Rafat.
Hello, Dr. Khalid. We have a lot of non-Arabic talking colleagues. Please.
Okay, sorry.
Yeah.
I just want to ask a certain question about the push maneuver or bearing down maneuver. So it's suitable to ask it now or to ask it later when there is more time to elaborate in discussing it.
Okay, now we are going to give the introduction for the course. So if you have a question regarding what Dr. Marwa have presented, it's okay. Otherwise, if for people who have experience in motility like you, Dr. Khalid, we will have a lot of discussions during the courses themselves. But if you have a question regarding the introduction given by Dr. Marwa, please go on.
No. Thank you. I will ask later. Thank you.
Thank you. Dr. Norman.
Yes, thank you, Dr. Mama, for the elaborative talk. Inshallah, through the course, when we go through that, and we'll discuss in detail. So that part will I know about the dark ages, how to come into the light age.
Yeah, but believe me, you will enjoy it. It is not dark.
I'm enjoying it.
I assure you. Because everybody thinks that esophageal high resolution manometry is easy and pH-metry is easy and anorectal is difficult. No, it is not difficult. Okay. No, if no more questions, we'll go to the darkest dark part.
Before I start, is this a good view?
Yeah, we see Dr. Maha.
Okay,
thank you very much, Dr. Maha. Will go to explain the biofeedback course.
Yeah, I've tried to do a very simple version of the biofeedback introduction session, so hopefully it will be easy to understand. So after we do all the investigations for whatever lower motility problem, the important question comes: what should we do? How we manage the patient? I think this is not an easy question to answer. So here comes the biofeedback. So hopefully by the end of this module, before I say that, so this module will entail what is defecation physiology, how we do defecate. If you understand the physiology and the anatomy in a very detailed way, you will understand how to manage that safely and effectively. So by the end of this session, all of you should be able to identify which patient to choose for the biofeedback, how to interpret all the findings we have, the anorectal manometry, the EMG, and so on, and how to do structured biofeedback session from start to finish. I've tried to collect all the questions. Sorry? Okay. I've tried to collect all the questions to make it easy. So I'll start by what is biofeedback, which biofeedback we should use, how does biofeedback works, where is biofeedback applied, and which biofeedback. So let's start by what is biofeedback. Biofeedback is retraining therapy. So we train the patients we're not doing any miracles. It's just training the patient to relax, to do the coordination of the whatever is weak or whatever is contracted, pelvic floor muscles or anal muscles during defecation or incontinence. The best thing or the most promising thing about the biofeedback is that the patient sees the problem by himself or by herself. So understanding the problem and seeing the problem on a screen, I think it's 50% of the management. So the patient sees what their muscles are doing, what is the defect. And our goal is how to control the defect, how to coordinate or fix the defect. Biofeedback is used when symptoms are caused by either abnormal muscle coordination or something wrong in the sensation, not by the stool consistency alone. I mean by that when the patient comes and complain with constipation or fecal incontinence, it's not the right time to go directly for biofeedback. And this is most of the physiotherapists do, unfortunately. They start biofeedback directly without knowing what is the problem, what is causing the constipation, or what is causing the fecal incontinence. So first we have to know which muscle is defective or which sensation and what is the problem exactly. The main indication for biofeedback, the dyssynergia, and we will know all about this synergia with Dr. Marwa and by myself as well. If there is functional obstruction, if there is chronic constipation related to abnormal push-relax pattern, or there is abnormal sensation in the rectum. And what I mean by this, that the patient doesn't have the sensation or the normal call to go to the toilet, or on the opposite side, the patient is hypersensitive when it comes to call to the toilet. Or selected cases of fecal incontinence. To be honest, not all cases of fecal incontinence is going to have the biofeedback. When is the biofeedback used? So this is the question. And unfortunately, the patient with a slow transit constipation, and this is a very important expression we have to understand. We will explain this during the module. And also with the structure obstruction, or when the patient is not going to engage with us, this is definitely contraindications to biofeedback. How does biofeedback works? It works through repetition, feedback, relearning. It needs lots of patience from our side and from the patient side. So we have 3 training techniques. I'm just mentioning the name, but we're going to explain all of these in details, inshallah, in the module. So we have the coordination training, the relaxation training, and the sensory training. Where is biofeedback applied exactly? So there are 3 main levels. We're going to apply the biofeedback on the muscle level, external anal sphincter or pelvic floor muscles. Either the muscles are hypercontracted or relaxed, the rectum, the sensation, the rectal pressure generation, and the behavior. I think the behavioral part is the most important part in the biofeedback. The posture, the time, the defecation technique, the diet, and so on. And we call this part the bowel training session. Which biofeedback should we use? So we have lots of machines that can be helpful. We have the manometry itself. We can use it to do the biofeedback. We have lots of EMG-based machines. We have other techniques we're going to mention. And as I've mentioned, and I will mention this over and over, that the bowel training is the most important part. Which patient, we're going to know through the modules in details, which patient who benefits most and how to set expectations. It's not like inflammation, it's not like Crohn's, for example, is going to take anti-inflammatory and that's it. No, it's a problem in the function. So when it comes to the function, it takes long time to be fixed. So as I've said, we have to use some investigations before deciding to do the biofeedback. So we usually do use the anorectal manometry. As I've said, it's the most important. The difficography, if it's available, MRI or barium, whatever. And in the biofeedback, this is very important to check the structural problems, the degree of descent, if there is rectocele or cystocele or whatever, the size of these things, because it has to be removed surgically if it's too big. For example, the rectocele above 4 centimeters has to be addressed in parallel to the biofeedback sessions. And the EMG, and we're going to see lots of types for the EMG. The bowel training session, this is very important, as I've mentioned before. So this includes the diet, So for example, constipation, according to the course, it has a specific diet. So slow transit constipation diet is different from habitual diet, is different from whatever other type of constipation. We have the era of the neuromodulators, and these neuromodulator medications, it changed the perception of the sensation, it changed the perception of the visceral reaction to bowel opening and so on. So the neuromodulators are very important, and the laxative. The world of the laxatives. What exactly are the laxatives? Which type we use? Do we combine things together? How combining things together, but safely? And we're going to see all of that. Very important aspect as well, the pelvic floor exercise. It's very hard for the patient to be committed for the pelvic floor exercise. What I do personally, I train them in my clinic by myself, and I use my finger to train them and so on. We'll see all of that. And then this encouraged them very much to be complied to them at home. In the hands-on part, we're going to recognize all the equipment that I've mentioned. The PTNS and SNS are not available in Egypt, but we will mention them at least. Maybe it's going to be available in your country. The baseline assessment. So in the hands-on, we're going to check how to look for the baseline assessment that is going to build our management plan for the biofeedback. We're going to see the training techniques, the 3 training techniques, as I've mentioned, and the bowel training session again, which is again and again is the most important part. The bowel training session, of course, it's a personalized plan according to the patient condition, patient lifestyle, patient problem, which function is defective. So it depends. We're depending on all of this information to build our bowel training session. There is very important role regarding the psychology role. Studies have proved that CBT and hypnotherapy, or at least in the hospital I used to work at UCL in London, CBT and hypnotherapy are very important in the bowel symptoms. Unfortunately, we don't have much of that in Egypt, but maybe you can integrate in your team psychologists that deal with CBT and hypnotherapy for the gut problems. And you will also learn how to discuss with the patient the long-term plan to fix the the functional problem. So hopefully by the end of the module, you will know when to use biofeedback, different approaches to biofeedback, and how to do this is very important long-term proper management plan. Thank you.
Thank you very much, Dr. Maha. This is a very, very important topic that we have to put in the course, even if there are no a lot of fans for this topic, because it complements everything. It complements everything. As Dr. Maha said, this biofeedback is the solution for many anorectal problem. So I thank you, Dr. Maha, for simplifying the topic, but I think it will need a lot of effort from you and your co-speakers in the webinar to explain it fully for our colleagues. Thank you very much again.
Thank you.
Any questions? We're going darker and darker. Okay, if this is a little bit clear, we can move to the next presentation by Dr. Iman. Dr. Iman will explain the advanced courses. You know, all what have been presented now is the basic course. Now we are going to the next level with the advanced courses with Dr. Iman. So please go on, Dr. Iman.
Good evening. Hello, everyone.
Yeah.
We will discuss.
Make the screen full screen, please.
Okay, it is full.
No, not yet. Yeah. It's down next to the 64%. There is a
Okay. After discussing the basic courses for the high resolution esophageal manometry and the anorectal manometry and the biofeedback with a pH impedance, will let us go to another part. As you know all that the medicine is not always black and white. There is always gray zones. Also in manometry and the motility disorders, there is a lot of gray zones we will discover and will go through. Not only in the esophageal, but also the anorectal. So we need to be somehow go to these advanced parts and try to discover these gray zones and develop an expertise in these complex cases and the provocative testing and the multidisciplinary management team. Just to know that sometimes that motility interpretation and cases for motility is not easy.
Sorry to interrupt. You are changing the slides, but it is not changing with us. Maybe you are sharing the other way. Yeah, just stop it and share again.
It's not changing?
No, stop your share and share again. Yes. You have to share the full screen slides, not the small ones. It's usual with Zoom users. No. Now I think it's going to be the right one. Yes. Can you change now? Go back one slide. Go back one slide. Yeah, it's okay. Just go back by the flavor.
No. F5, Doctora. F5. F5 from up. F5.
Okay. Now it's changing. Is it changing now?
No. Go to the previous one. Not this one. Go to the previous one.
No, please. Okay.
No, you are sharing now the desktop, the computer, the view of the computer, not the slides.
Okay, it's somehow
just stop
somehow.
Choose Open the file first. Open the.
It's not shared yet.
No, you are sharing the files in your computer.
Okay, I think it will be. It takes some time.
Yeah, just close this. Yeah.
Okay.
Open the PowerPoint and then choose it from the share.
I'm already opened it. It's okay. Let me try again. I'll close all the windows and. Okay. Is it okay now?
It's opening. We'll see. Yeah. Can you change now? Next. Yeah. Just click it. Yeah. Okay. Go on, please. Yes.
Yes. Okay. Yeah. We were discussing that the motility interpretation and motility cases sometimes is difficult for experts even for those who has been working with the interpretation and working with motility for 10 or 20 years. So we'll go through the advanced parts of the motility for the high resolution esophageal manometry first. In this course, we will discuss parts which is not will be discussed in details in cases with basic esophageal manometry. We will discuss variants of Chicago 4 classification, like parts with esophagogastric junction obstruction versus clinical esophagogastric junction obstruction also, and what is the significant if it is only a manometric finding or it may rely for a clinical symptom for the patient or something like that. We will also discuss the variants of the break peristalsis with large breaks and the ineffective esophageal motility variants, the significance of the fragmented peristalsis. As we know that in Chicago, or as we will know that the Chicago classification, when it is already evolved into Chicago 4, in the previous ones, they were using parameters which is not used nowadays in Chicago 4, like fragmented peristalsis or large breaks. It's not used any more in Chicago 4. So we will know how to deal with these parameters for the cases with Chicago 4 also. We will go to the complex of esophagogastric junction and know the variants of the esophagogastric junction complex, which is 3 types, type 1 and type 2 and type 3. And then we will know how to discuss or how to discover the type of this esophagogastric junction, and which will lead us to know the hiatal hernia and its size, and how to discuss and how to discover hiatal hernia and how to deal with through the manometric interpretation. Also, we will do in the advanced courses the provocative test, which is an adjunctive test for better interpretation for motility and better interpretation for the patient's symptoms. If the patient is still complaining and the basic finding or the basic 10 swallows are not discovering what's the matter with the patient, we need to do some provocative tests like multiple rapid swallows, which will assess the peristaltic reserve, rapid drink challenges, which is screening for the outflow obstruction, solid test to swallow, which will also reveal some types of dysphagia for the patients, and also some pharmacological challenges, which is, although is not usually done, but we will discuss its effect. We will discuss the role of high resolution manometry in the context of GERD. Although the high resolution manometry and the lower esophageal sphincter pressure we cannot rely on for GERD diagnosis, but we need it in cases of association with hypotensive and ineffective esophageal motility. For the pre and post operative assessment for anti-reflux patients before anti-reflux surgeries need to do high resolution manometry and to be assessed for good peristaltic reserve and the prognostic factors for possibility of dysphagia post-operative. Also in the post-operative, we need to assess the patients for this surgery if the patient is complaining of any dysphagia symptoms. We will discuss how to use the high resolution manometry for this non-standard indication, like in patient with unexplained chest pain, patient with systemic sclerosis or connective tissue disease. We will integrate high resolution manometry with other diagnostic, like using the barium esophagogram timed or solid, the correlation between the pH impedance finding with the high resolution manometry, and also the role of endoflip with the high resolution manometry. We'll go through this through case studies, integrating the history taking, the impedance and the pH, impedance pH and the high resolution manometry together with a group discussion to reach the full benefit from this advanced course. Also in the high resolution advanced course for the anorectal manometry, we'll discuss certain points which will be elaborated in the basic course. We'll go through in details in the advanced course to develop this expert part in the complex cases. By the end of this course for advanced anorectal manometry, we will be able to interpret complex high-resolution anorectal manometry with confidence, correlate the manometric finding with the neuroanatomy and the floor pathophysiology, differentiate overlapping disorders, also integrate the anorectal manometry with the balloon expulsion, difficography, and sensory testing. The use of anorectal manometry to guide targeted therapy, as Maha said, that it's very important to reach the diagnosis in order to offer the patient a tailored treatment in the form of biofeedback or neuromodulation. And this is an important part after the using of anorectal manometry. Also, anorectal manometry with complex population, post-surgical or in patients with neurological disorders or in pediatric age group is very important part will be discussed. We will discuss parts in difficatory disorders like ROM 4 criteria for dysynergic diffication type A to D, the paradoxical contraction versus inadequate propulsion, and the difference between the anorectal manometry and the balloon expulsion tests. For the fecal incontinence cases, we will discuss parts of the sphincter and the sphincter weakness versus sensory dysfunction, the rectal compliance curves, post-obstetric and post-surgical and post-radiation induced injury, which will cause fecal incontinence, and also predictors for response to biofeedback and sacral neuromodulation. For the rectal sensory testing, we'll the sensory testing from the start, from the basic part will be discussed, but we will have a session to differentiate between the balloon versus the barostat, which is for the rectal compliance, the hypersensitivity and the hyposensitivity, and we will interpret some pitfalls which may be happen during the anorectal manometry during the during the test or the interpreting the manometric study. Also, we will go through some basic anatomy, which will be deeper, like internal and external sphincter, the puborectalis muscle mechanism, incontinence and defecation, the autonomic and somatic innervations, the rectoanal inhibitory reflex, when it will be with subtle abnormalities or false absence or versus true Hirschsprung spectrum, with the visceral sensory pathways and the cortical modulation. Anorectal manometry in special population like patients with neurological disorders, pediatric anorectal in cases of megarectum and Hirschsprung is an important issue with adult implication, and also the geriatric pelvic floor dysfunction. I know it's somehow it is changeable with other, and all of us are sharing the same topics, but it may be in details in the advanced course. Lastly, in the anorectal manometry, as my colleague said, that we will also know how to integrate both anorectal and other modalities. And finally, the most important thing is the guided therapy and biofeedback optimization. Thank you.
Thank you. Thank you, Dr. Iman. It's getting much complicated. So, any questions for Dr. Iman? Okay. Then, so I will end the session today by the assignments that we will have during the course. The roles of the assignment is to deeply understand the topics. So if anyone of us is having a webinar or a theory without any application or without any practice, he will lose the information by time. But if you do it yourself, or if you do it with a group, if you practice this many times, the information will be solid for forever. So we will try after each webinar to give some assignments for topics related to the GI motility disorders and also other topics that are not related directly to the motility, but they overlap with the motility, like the functional disorders of the esophagus, for example. So these assignments will be done in groups. So we will divide ourselves into groups, and each group will have one assignment, and they will work together for a week over this assignment, and then we will meet the week after. So starting by a webinar, then the next week will be non-working day, but non-working week, but we will work on the assignment, and then we will meet the third week to discuss this assignment, and then we will apply cases in the fourth week after that. So I hope that the course will be beneficial for everyone, and I hope also to hear from you your feedback, and be honest about the feedback. You can contact us by email all the time, and we will formulate a WhatsApp group for this batch for this year to communicate all the time and to ask questions all the time. All my colleagues here are ready to answer your questions, and then we will do small groups for the assignments, so everyone will interact in his small group. So finally, I'd like to thank my colleagues, and I would like to thank you all for attendance, and the floor is open for questions now, please.
في دكتور محمد some points كده. One question, the effect of sedation, low dose sedation, like 2 milligram dormicum, maybe in the motility study for esophagus hydrocephalus.
No, I don't think this is relevant, because you have to have your patient cooperative to do this.
No, I know after yeah, I give this sedation to confirm that the catheter inside pass the cardia, and then I wait till patient to become conscious, cooperative, and start my test.
Can I answer?
Yeah,
question?
Dr. Aman, please help us.
Okay. Dr. Ahmed, how are you? Nice to meet you. From my experience, because we usually have children to do the manometry, and sometimes it is difficult to do it in children. If you give the patient dormicum, she will have collapsed the upper esophageal sphincter, and you will not enter the catheter easily. It will not pass through the upper esophageal sphincter with ease. It will be more difficult.
I know. I introduce the catheter till mid-esophagus because patient has tight cardia.
This will not differ even if you give her this, because we usually do in these cases do endoscopy and put the catheter under endoscopic guidance. And even with endoscopic guidance, we cannot do it, because it's not only tight cardia, it may be tortuous esophagus. If tortuous esophagus, the catheter will be in the upper esophagus. No, not kinked. In one of the parts for the tortuous esophagus, in one of the pouches. And you cannot go through the pouch to the end of the esophagus. So it may be not entered to the cardia because of the tight LES or the tortuous esophagus, tortuous dilated esophagus. So if even you give this midazolam or dormicum, it will not affect the entrance or the passage for the cardia. And even it will be more difficult.
Explain, Dr. Ayman.
The question
yeah,
is...
I know you, Dr. Ahmed. Just a minute. Dr. Ahmed already gave a patient a sedation, and he introduced the catheter to the patient under sedation. And he's waiting till the patient wakes up from that sedation, and then he will do the test.
I did already this.
I have a question for you. For how long should you wait till you do the test?
30 minutes, no problem.
Okay. I have
I just want to know, Doctor, your aim of this sedation, to pass it easily without the patient annoying from the catheter?
To pass the catheter by endoscope, because every time reaching the cardia, kinking, go out.
So you are just putting the endoscope also, not only for by the catheter. Okay, it is endoscopic guided.
Yes.
Okay, so I don't know what's happening at your place, but in Egypt it is more costly for the patient to he will pay for the endoscopy and for the motility.
Patient already abroad for EGD before, and we did EGD.
Okay, so what's the indication to have another EGD? Just to put the catheter.
Just to put the catheter, because it's the only way to pass the catheter through the cardia.
Oh, okay, but it will not be always the same that you will pass the catheter?
Not every time. But the question, does this sedation affect the interpretation of motility?
It will affect somehow for 30 minutes. If the patient is normal, but if the patient is achalasia, it will not affect.
Thank you.
Sometimes you need this. Sometimes you need this.
Yes,
don't do it with a solid state catheter, please.
I'm doing it with a solid state, Dr. Muhammad.
Yeah.
But we do not direct it with the force. I don't direct it. I do not have something to direct the catheter to pass through the LES. If I could pass the LES guided by the endoscopy, I go. If I couldn't, because of the dilated esophagus, I don't try to push because I don't want to lose the catheter.
You will lose the catheter for sure. Yeah.
Yeah, alhamdulillah, I test the catheter after the test, and the calibration is good.
Alhamdulillah. You're lucky.
Alhamdulillah.
You are taking it by forceps or by snare or something?
Once I enter the endoscopy through the cardia, and
besides the endoscopy, right?
I'm ready to use net at the time if not pass.
You're ready to use what?
Net.
Ah, okay. You use the net also if it is not pass.
Yeah, yes.
But the net is also somehow made injures the catheter. It's better not to use it.
Pass يعني without net this time.
Okay.
Second, I asked about the literature and the record we will take.
I have a comment regarding the
endoscopy. Yeah, please. Yeah, this is a very relevant topic, and
very good question.
I need to add a disclaimer here before you. Please don't do this at home. You know that advertisement. Don't do this at home for dangerous jumps and those. Yeah, what is Dr. Ahmed doing is a little.
It's very risky.
Yeah.
So, there is a report for this.
Yeah, of course. But if you want to sacrifice one catheter, you can do this. But not every one of us has the luxury to sacrifice a solid state catheter.
Well, in my experience in London, so we do this in a few patients, but only because they are not really engaging with us. It's not because the tight pylorus and so on. This is if it's tight and it's turning back and kinking or whatever is happening. So this is a sign of achalasia and full stop. So you just need to do timed barium swallow to develop how much or what is the length of obstruction, and then do the intervention and remeasure the length of obstruction and full stop. The only way or the only reason you can do by endoscopy that the patient is so stressed or there is a nose problem and the patient is not engaging and she's really or he is really going to benefit from the test. And we do it with the solid. We don't have water in London, but that's okay. But only if the patient is not engaging. That's the only reason. If it's tight, this is achalasia or OG obstruction. So go for, if there is endoflip, that would be fantastic. If there is tight barium, that would be enough. And that's it.
Endoflip is coming. Endoflip is in Saudi Arabia very soon. It is in the region now. It is in Abu Dhabi. It's present there.
We're waiting as well.
And we are waiting. It will come to Egypt soon.
Inshallah.
Yeah, this will solve a lot of problems like Dr. Ahmed said.
Yes.
Okay.
Another question asking about the lab scene design. Yeah, the room. Is there special design for the motility lab?
No, it can be done in any room, in any office. But
regarding anorectal testing,
anorectal is different. Anorectal needs a quiet room and it should be some sort of private and away from the waiting areas and the noise, etc. And should have the commode and should have a station for digital rectal examination. We will show this during the course. It needs some preparations also, but it should be in a quiet place and it should have privacy.
Okay.
Okay. Any more questions?
I'm so happy that there are some questions. Hopefully, so question means that the people are engaging with us.
Yeah. Okay. So if no more questions, I would like to thank you all, and we will see you in the first webinar. It's supposed to be on 13th of February. We will send you by email all the information and access. And hopefully, if you have gained some information from this webinar for the beginners, please send us your feedback. We will start the WhatsApp group maybe tomorrow. and then you have your feedback. Be honest, don't be shy. Please give your feedback for improvement. We are all colleagues, no instructors, no trainee here. We are all at the same level. We are learning all together. Thank you very much.
Thank you, Prof.
See you all. Bye bye.
Thanks.
Bye.
Bye.
Thank you.
Thank you.